Okay, good afternoon, everyone. I think we will get started. Thank you for joining us for this month's Teach Educational Rounds. Here with us, we have Dr. Peter Selby, who will be presenting Smoking Cessation Best Practices in 2019. But before I hand it off to our presenter, I'm just going to go over a few housekeeping slides as per usual. So first of all, if you're interested in obtaining a letter of completion for this month's Teach Educational Rounds, please make sure that you have registered for the webinar and completed the pre-learning assessment. You have signed in to view this webinar using your first and last name so we can track your participation. And finally, you complete the evaluation and post-learning assessment, which will be emailed to you today, and you'll have 1 week to complete that. These webinars are being live tweeted, and you can follow us on Twitter at PSQuitSmoking or use the hashtag TeachWebinar to post or read questions. Here is the faculty biography of our presenter, Dr. Peter Selby. He is Chief of Medicine in Psychiatry Division and a clinician scientist at the Center for Addiction and Mental Health. He is a professor in the Department of Family and Community Medicine, Psychiatry, and the De La Lena School of Public Health at the University of Toronto. He is also a clinician scientist in the Department of Family and Community Medicine. You can read more about him on this slide. Here are a list of his disclosures, as well as our disclosures. And this is just a friendly reminder that the content of the Teach Educational Rounds are based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentations and any discussions, set out only general principles, and they do not replace the need for individualized clinical assessment and treatment plans by healthcare professionals. And before I hand it off to our presenter, I'm just going to do a few polling questions to gauge who has joined us here today. So in a minute, could you please indicate which of the following organizations you work for? And if your organization isn't here, you can type it in the chat box. So it looks like we have some family health teams, public health units, hospitals, great. And I just want to check, can everyone hear me? I just got in the chat box that people can't hear. Great, thank you. And again, can you please indicate which of the following discipline you work for? And you might need to scroll down to see all the options. We have some addiction counselors, health promoters, quite a few registered nurses joining us. Great. And for the last poll, could you please indicate which region you serve? So we have quite a few from Central East area, Peterborough, some out of province, that's great. BC, Manitoba. Okay, great. Thank you, everyone. So without further ado, I will hand it off to our presenter, Dr. Selby.
Thanks very much, Stephanie, and good morning or afternoon, everybody. I guess, first of all, I can't imagine that you are all here on a March break. Wednesday afternoon in the middle of March break, I didn't think we'd have anybody showing up, but so I appreciate that we have so many people signed in. We thought it would be a good time to do some updates and to also talk a little bit about what we are learning from the STOP program. And first of all, thank all of those of you participating in the STOP program. Without you, I don't think we would have reached these people who are struggling with tobacco, and we get to do the follow-ups and we hear what impacts you're making on people's lives. It's quite compelling. Every Friday we get a quote from somebody, and it really helps us know that you're doing some really great work. And when we look at the patients who are coming in, the current smoker coming into your settings, no matter whether you're a family health team, nurse practitioner-led clinic, CHC, Aboriginal Health Access Center, or an addiction agency, the patients are looking pretty similar in terms of their comorbidities. You're getting really sick people coming in to quit smoking. they on average have 2 or 3 diagnoses, which is quite interesting to us. Anyway, so let's move on. We only have an hour today, so feel free to as usual, keep typing into the chat box if you have any questions or comments as I'm going along. If you can't hear, etc., there's somebody else standing by in case you cannot hear me. All right. So what are the learning objectives of this in the next hour? 3 objectives: identify an ideal first-line treatment for smoking cessations, depending on the patient. Integrate your behavioral support into the treatment plan, and recognize the signs that cessation treatment may need to be adjusted because, as you know, this is no longer just a single visit providing somebody smoking cessation and then leaving them to their own devices. So how do you go about identifying the first-line cessation treatment? So all of you are familiar with CANADAP, which is our guidelines that we develop with the funding from Health Canada, which is no longer funded, but it continues to live on in different ways through different groups, and clearly we think that it's still valid in terms of its recommendations. What we have done, though, is updated the algorithm, and don't try to read it, just to give you a screenshot of what it looks like, and these algorithms are available for download and can be emailed to people if they're interested as well. So it's a two-pager on 2 sides, and it covers that. And we will go through it in closer detail. We'll be zooming in as the presentation goes on. But I'd like to start off with a patient or a client. And interestingly enough, patients with schizophrenia are showing up in the STOP program in primary care settings in terms of 8 times what the prevalence would be in the general population. So it's like, so you are seeing these patients, and I'm going to use this as an example of how one can approach the current smoker who might have a severe mental illness. And so let's meet John. He's between 40 and 50 years of age. He has a diagnosis of schizophrenia, has been suffering from anxiety, smokes 2 packs a day, tried to quit cold turkey several times unsuccessfully, and medications include antipsychotics. So 1 antipsychotic is olanzapine, 15 milligrams per day, atorvastatin, 40 milligrams per day for his cholesterol, ramipril for his hypertension, clonazepam for his anxiety, and quetiapine to go to bed at night. And so these are the medications this person is on. And actually, when you take a further history, you'll realize that those 2 packs a day are often bought with contraband cigarettes and the low cost, and he's buying them off somebody who's selling them a bag for really a ridiculously low amount of money. So when somebody like this comes in or and it says, I want to address my smoking, where do you start? What do you say? So first thing is to obviously assess where are they. Are they ready to quit within 30 days? And why are we going to that? Because when you scour the evidence and you look at the published evidence, for those who are not ready to quit in 30 days, really the work to be done with them is to use motivational interviewing to help them reduce their ambivalence and enhance their readiness. So this is like how you have a patient who may be going for an operation and they are not stable, metabolically stable, their diabetes is out of control, etc. Nothing is out of control. You stabilize them first before you try to go into the operation. And it's no different than the procedure of trying to get somebody to quit smoking. Try to maximize and get them ready to be able to set a quit date within 30 days. So some of the things that people can do that we often, which are measurable behavioral outcomes that gives them some opportunity to get some control back, is to make their home and travel and work smoke-free. And the second is to track their smoking, whether it's on paper, on a smart device, however, just make every cigarette a conscious act. By doing this, by making people more conscious of what they're doing, they automatically start getting more aware and they start cutting back even if they aren't ready to quit, and it can help build the confidence to start that quitting process. So really in that guideline you'll see the motivation interviewing close up. It's a little quick and dirty of it. Of course, this is just to encapsulate some of the key points. It's just ask the readiness to quit and the desire and confidence. And some people will use importance or desire, but really it's to get at that issue of how important is it for this person to quit on a scale of 1 to 10. There's no it's like how we scale pain. It is completely situated within the patient. There's no absolute numbers here that you have to follow. But generally, the greater the importance, the greater the confidence, the more likely the person is ready to make a quit attempt. If you have a discordance in that, with either low importance or low confidence, generally you do need to use a motivation review. You find out what it is that it is about smoking and how does smoking fit into their health, family, and social situation, their rewards potential of quitting, what might happen, what are some of the acute risks from continuing to smoke or the chronic risks from continuing to smoke. What's coming in the way of them quitting? Is it withdrawal? Is it fear of failure? Is it giving up a good friend? What is it that they're worried about? Are they worried about weight gain? And then, essentially keep this going. So these are often known as the 5 hours of motivational interviewing using reflective listening to help people move along that. Now, for example, the other day I had a patient who's, in his late 70s, almost 80 years of age, and has cardiovascular disease, but is otherwise well, functional, has diabetes under control. And he came, he did a 2-hour journey to come and see me to quit smoking. And I'm saying, so what is driving you to quit smoking? Because he's saying, I'm having a good life. And I asked him, what's really driving you? And one of the things that came out from him is, I thought it would be health, but really what came out from him is he says, I've accomplished so much in my life. I'm a role model to my family, and when I smoke, I lose all the respect that I have in my community, with my family, and I don't want that. I don't want to just hide and smoke. So it's important to find out what resonates with somebody, and that's one of the ways in which you can do that. So getting back to him and finding out that he's in the preparation stage, he's ready to make a quit attempt in the next 30 days. The first thing is to find out, because he's such a heavily dependent smoker, is to find out, are his medications covered? Is he on Ontario Drug Benefit? This is in Ontario, so the provincial drug plan, or does he have private insurance coverage? When we look at our STOP participants who've come in, 40% of them, so essentially almost 1.6 of them have Ontario Drug Benefit coverage. What does that mean? That means they would be eligible for both varenicline and bupropion for 12 weeks, or bupropion for 12 weeks every year till they maintain a sustained remission. So it is another option that we need to ask about, because this is something that people can use. And it'll make sense as we go along as to why it's important to ask about that. And of course, sometimes clients can afford to pay for medication and want to pay for it either because they're committed to this and they don't mind paying. And then we always want to find out, what have they tried in the past, and did they have any serious reaction side effects, and how long did they take it? Because sometimes people will say, I tried that medication, it didn't work. Well, they only took a dose, or they took it half the dose, or they only took it for a week, or it did help them quit, but they relapsed 2-3 months after they stopped the medication, and they say the medication didn't work. The issue is the medication did work, something else came into play and caused a relapse. So we can talk. So you need to find out what they mean by when they said they didn't work. Now, of course, if they had serious side effects or reactions, that certainly rules out those medications. But otherwise, we want to find out what's going on. So now we take a look at the medications close up. What are the options for John that we might want to look at? So clearly, generally, these are the medications that we have with respect to what is covered under the Ontario Drug Benefit is varenicline and bupropion. And one of the things that you may or may not know is that now varenicline has gone generic. And so I think we are one of the first countries in the world where this drug price will drop. It's probably dropped by about 25%. And once there are 3 generics on the market, the price will drop down by 75%. So it'll be really a cheap, safe and effective medication on the market. It's not over the counter, but it still will be relatively affordable compared to everything else. So usually varenicline we will start with the starter pick and the continuation pack, and it's $260 for the brand name, and the generic is about $188 for 4 weeks. So for the total 84 days for the whole treatment. So I think you can see how the price is coming down, and it should get down even further over time. And bupropion, that's the Zyban, but if you take the generic, it's like $30 or something, because the pills are really cheap. So we haven't got that in there, but take a look at that and consider it as an option. So really, if you're looking for efficacy, so if you look at this gentleman, John, who has got schizophrenia, and if his schizophrenia is stable, so that means he hasn't had an admission in the last couple of years, he hasn't had a change of his medication, he's not having any active psychotic symptoms, and he's otherwise stable, you would go for efficacy. Especially if he's beginning to have health-related complications because of his smoking, you really want to help this person stop as soon as possible. And that's why we would pick the most medications now that have the best quit rates. It would be a very different matter if this man was 18 years old, no other health problems, and he was coming in for the first time to quit. You may not even give any medication. You may simply do a behavioral intervention. But if people are starting to develop these health complications or, there's a really good need that they need to quit, then you're going to go for the most efficacious medication. This is what we do for hypertension treatment. This is what we do with cholesterol reducing. This is what we do with most other conditions. We don't necessarily just give the medication out of a recipe book we contextualize it to the patient. So really, in somebody like him, if he's stable, we would prescribe the standard dose. As long as he's well and otherwise has no problems, his kidney functions are fine, you just provide the standard dose, and we'd follow up in 1 to 2 weeks. Prior to starting, of course, we would do monitor the mood and obviously do a PHQ-9, and the group participating in STOP does that fairly regularly, so that's a great 9 questions very quickly, tells you where somebody's at baseline. And if it's low, it's not in any active range, less than 10, pretty much that's a good way to go forward. And there's a last question, the PHQ-9, that asks about suicidal ideation. If that's negative, really you could start going forward with this. The heaviness of smoking index just tells you how heavily dependent they are. And if there are any concerns about, you do form a suicide risk assessment, which is really a simple assessment to look at what the imminent risk is. And clearly the biggest risk for suicide risk is previous suicide risk. And again, having said that, that is being abundantly cautious, as will become evident in the next few slides. And generally people need some sort of behavioral recommendation, whether it's in person, through groups and individual, or smokers helpline, or online, or other community resources. Generally, the addition of behavioral interventions makes a difference, and even if it's a short, brief intervention with you while you're getting them assessed for medication or counseling them, that's often good enough for many people. The other option is to provide bupropion to this gentleman, which is again a standard dose, a follow-up at 1 to 2 weeks, and obviously similarly do the same kind of assessment. The issue with bupropion is that the person should not have had a history of seizures or drinking alcohol to excess or any of those problems. And the anxiety sometimes with people with bupropion, especially if they're drinking great levels of coffee or caffeine, when they quit smoking and combine that with bupropion, the caffeine and bupropion make them feel kind of jittery, and they'll typically tell you at the end of the day they're getting shaky. So other than that, there aren't really any major reasons not to use it, and it's a really cheap option. The generic is really dirt cheap. Now, why are we going this way, and why aren't we saying start off with nicotine replacement first? Now, this is a recommendation. At the end of the day, you're going to negotiate with the patient, and it depends on what the patient is willing to take. It's not just what the evidence says. It's the evidence combined with the patient's acceptance and willingness and situation that these recommendations are going to be made. So many of you may be familiar with this large trial, head-to-head trial that compared placebo with nicotine replacement and bupropion and varenicline in smokers between the ages of 18 to 75, and they all smoked more than 10 cigarettes per day, and they could have psychiatric conditions, and that's the difference. That they were people who were with psychiatric and without psychiatric conditions, but basically What it means is that if people were provided either varenicline, bupropion, or NRT compared to placebo, they did much better in their overall quit rate, regardless of what it was. And so if you take a look at those abstinence rates in the short term, while they were on the medication, you will see it's from 1/3 to about only 10%. It's about 20% to 10%, and so you can see in that middle, the third column from your left, what the abstinence rates are at the end of treatment in that, so 4 weeks continuous abstinence. And keep that in mind, because that's an important outcome for tryers to achieve when people are quitting smoking, is how long can people go without smoking. And so if in 1 in 3 people are able to make it versus 1 in 5, you're going to pick the 1 in 3. And so, of course, when you stop the medication, you start getting relapse over time, but you still have an impact of the medication persisting out at 6 months. So usually when we start a medication, you want to reassess within a week. Sometimes it's not possible, so between a week to 1 month. And you're going to, and it's definitely a hard stop at one month, because between 1 week to 1 month, you may want to assess for whether they're having side effects, whether they're taking the medications, and that'll become evident because most of the relapse happens in that first few days after the quit attempt. So, but why reassess definitely at a month is because the patient could have quit. With varenicline, people may not quit necessarily in that first week, but they can keep quitting and responding up to a month after they started. So don't abandon hope too soon with varenicline, because you do see this recruitment. And then I'll bring up what you're going to ask about is how long have they been able to go without smoking at that, when you see them at a month, have they gone at least a day? Have they gone a whole week and gone back, or have they been able to go a whole month? So 4 weeks continuous abstinence and are going on. Because if they have made that 1 month, then you're starting to move more into relapse prevention, which would be continue the medications, continue to provide the behavioral support, and that's one pathway. But if they haven't quit, or they haven't gone for a whole day, then usually that has something to do with motivation. They're not able to even take that step, and that's where you know you have to focus your intervention. On the other hand, they've been able to go for a week but went back, then you know that they have the motivation, they're making that attempt. They're not able to make that week because the withdrawal is a bit too much for them, and so you need to maybe help them figure out what they might do for that withdrawal, whether it was stress-related or cues or physical withdrawal or something else, like the cues around them. That's usually what you might need to focus on. Or lastly, if they've been able to go for more than a week, then pretty much that means withdrawal is no longer, and if they're going back, it typically has to do with habit or opportunity or something stressful that is bringing them back, and it can help focus the counseling and the medication as to what they might need to do. On the other hand, if you've had somebody who's reduced, so they haven't made a quit take, and you're saying, oh, well, did this person not even shift in the amount they smoked, then you're going to have to encourage the MI. But if they have reduced, and then you're going to say, okay, well, where are they? What has this done to their confidence? By reducing, has their confidence gone up from baseline? So maybe at baseline their confidence was a 5. Now their confidence is 6. And they'll sound like they're saying, you know, doc, when I saw you, I wasn't that ready, but I've done the monitoring. I've been monitoring. I've been looking at where you are and at where I'm at, and I've actually been able to bring down some of the cigarettes. I haven't quit yet, and I'm more confident that I should be able to go that way. So we have patients who take that pathway in how they're quitting, and this is how you manage them. And you may add or switch meds if they're reduced, and typically it may be you may add another medication that helps them achieve that outcome. Typically, there have been no change in the sense they're saying, I am motivated, I do want to stop, I've been trying, I did even try going 24 hours, but I went right back. Then your options are to switch away from the medication to either bupropion or NRT, because there's no indication that the medication is doing anything. They're smoking the same or more, then there isn't any point in continuing that medication after a month. So now what do? Suppose the patient or the client isn't interested in meds, prescription meds, and says, no, I don't want to take prescription meds, or the options 1 and 2 didn't work, or whatever 1 and 2 is they're not tolerant to. You have option 3, and option 3 becomes NRT. And interestingly enough, nicotine replacement is what often has been the preferred, but from an efficacy perspective, you've got varenicline first, then NRT, and sort of equivalent to bupropion. And so that's what we often recommend. And NRT with a patch plus a short-acting has relatively the same effectiveness as varenicline. So we're just talking about ways to think about it differently, that broadening our options of how to do that. So clearly we would refer to the NRT algorithm, and there we are talking about light smokers being less than 10, and 10 to 29 being the moderate, and more than 30 being the really heavy. You will see different definitions of light, moderate, heavy. Some people will say 10 or more makes them heavy. This is just how we've operationalized it, and generally the reason for doing this is to prevent any kind of toxicity and to quickly go up as quickly as possible in these patients. So for 10 cigarettes or less, it's 14 milligram patch. 10 to 29 will start with a full dose patch, and if you get up to 30 or more, you're starting with a 28 plus 7. So this person would start with a 28 milligram patch if they were going to go with that. And we would add 1 short-acting only. There's no evidence of using 2 short-actings at the time. And in fact, when we look at our stop data and look at people who are using more than 2 short-actings, they tend not to do well. So it's really something to think about why we're trying to give more. And of course, reassess weekly, bi-weekly. And again, if similarly, within a month of NRT, if they continue to smoke and they haven't, then there are some problems. They haven't reduced. So if they are not smoking at all and they quit, obviously you continue that same day. But if they're still smoking, you can add, if they're smoking 10 or more, we'll add another 21 milligram patch. If they're smoking 6 to 9, we'll add another 14 milligram patch. If it's 1 to 5 cigarettes a day, we'll add a 7 milligram patch to their current dose, plus offer them a short-acting NRT for breakthrough cravings as needed. And over time, what you would see is that the need for the breakthrough drops as they're getting more and more of their nicotine through the patch. And that ideally is how you want it to be, because that really helps get rid of not only what we would call the tonic cravings. That means cravings that are there all the time, and that's because they're just not having enough nicotine. It should take care of that, but it should also take care of the chronic cravings, which means cravings that come in response to cues or triggers. So they had a cup of coffee, or they went out for a drink, or they had a meal, or they took a break, or or they were stressed. It didn't lead to a craving or a lapse. They may have had a minor craving, it became a manageable one, and they were able to move it out. And so trying to titrate the dose is really critical in this situation. Having said that, you have to instruct people who continue to use cigarettes on top of this. There's a theoretical risk of toxicity But what we do is to make sure that our patients understand that if they are reaching for a cigarette, that's typically because the automatic or the habit part of the brain circuits are kicking in. So don't just continue to smoke like you normally do. Have a small puff if you're really going to have one. So you've tried all your other things. You've tried deep breathing. You've tried your 4Ds. You've tried the gum. You've tried everything, and you're reaching for that cigarette. Then have a small puff and see if you need it, because often what happens is when the dose of nicotine is right, people will simply say, look, I had a puff and it tasted horrible and I couldn't finish it and I didn't want it. Whereas if they're in true withdrawal, they'll say, well, I had that cigarette and my withdrawal went away. Then you know that the patches are not strong enough, or the NRT, short-acting NRT is not strong enough. So you know you've got some room to up that dose. So that's how we approach it, and this is obviously off-label, but that is what we are studying we've studied in open label, but we're now studying in the nicotine to effect trial that's happening at CAMH and the Ottawa Heart Institute to see if in fact the high doses make a difference. And we go up, we've gone up between, for this protocol, we say 84 milligrams, so 4 patches of 21. And those are in the people smoking, 3-4 packs a day. But I've had one patient who's smoking 100 cigarettes a day, and we had to go up to 5 patches before he was able to stop completely. But again, I wouldn't do that without supervision, and he did fine. So that's our approach, and then this behavioral plan into supporting the treatment plan. And we're now going to just cover what does that behavioral plan look like. Often you notice they are either fixed groups, so that session 2 everybody has to set a quit date, or session 3 this has to happen. So I'm going to tease apart what are the core elements of what needs to be done. So clearly, if people set a quit date, they're more than 10% more likely of being quit at 6 months follow-up. And I think people don't know that when they're coming in, that setting a quit date really helps them get there. And you can see that in the criteria that we're trying to move through STOP, is that people who are interested in making a quit date in the next 30 days are really the ones who you want to start working within STOP, because that's the group you're going to get the best buck for in terms of quit rate. If they're not ready, we'll talk a little bit about that, but always encourage the behavioral interventions because it sort of amps up the effects of the medications, and regardless of which medication they're using. And of course, if your setting does not allow, we have the Smokers Helpline, telephone line, online support, and if the patient is willing to do that, then it's a great option. What are some of the messages that we want to offer the clients? So obviously, you have the STOP change plan workbook, but what do we know that is important? So one is that smoking has become automatic, and you have to make it bring it back under volitional control. And in that early stage, the volitional control is not perfect. It in fact can only do it maybe occasionally, and that's why you need the medications to help boost that volitional control. But at the same time, while they're on medications, you want them to start learning about tracking their triggers and becoming aware of the people, places, things, and events that make them smoke. And start getting them to reflect on their cigarettes and rate every cigarette, because cigarette smoking often can become so mindless that people will say, you know what, I was expecting to get something from the cigarette, but after I smoked it, it really didn't do much. And starting to help become more aware is one of the first steps. The second is obviously developing coping skills to prevent them from smoking when exposed to triggers. So this is the 4 Ds, the distract, delay, drink water, deep breathing, which is a common thing, and get them to articulate how they operationalize those those issues. I have some patients who told me that they like to draw, color adult coloring books because they like to have their fingers busy and they want to be distracted, but it's a little hard to do a coloring book in the middle of a workplace. So then they had to come up with other ways to distract themselves. Delaying was a lot more easier when they were in situations where they couldn't smoke. So if they were in a workplace or a social situation where nobody was smoking, they found it a lot easier. So hanging out in places where smoking isn't allowed is another way to help people actually delay that smoking or drink water that can sometimes help manage cravings. We don't say drinking juice, although juice is effective. The problem with that is that, and sugar is effective in mitigating nicotine withdrawal symptoms. The problem is the sugar control that goes out of whack, and you're setting them up for becoming gaining weight. So we tend to avoid that. And of course, other ways to do this is deep breathing to help them manage the urges to smoke, and just being a mindful minute to go through that. So those are in the moment things that they can do. And then we also want to make them in sort of looking at how they can manage their overall health. So we know physical activity is a great, has been associated with health benefits across many conditions, and including acute bouts of physical activity can help with cravings. And clearly, obviously, based on our patient profile, who is not really very well, you would start slowly and then increase it. And obviously, this needs to be added to the repertoire. It can't be the only thing. And then choose healthy snacks and foods to improve nutrition. Clearly a really important thing, because when people are in withdrawal from nicotine or any addictive substance, they crave sugar. And that craving can then lead to another problem, which is excessive consumption of refined sugars, which then leads to weight gain. So choose healthy snacks and things with crunch and texture that can help them keep busy. Practice mindfulness to become more aware and stay present. So, and this is easier said than done. Not everybody is willing to do that, but if you can see, people with more time and a proactive approach are much more on the right-hand side of this slide, and in the moment it's in the middle, and then the third is obviously managing the environment. So a couple of ways that even though it's the person doing the changing, some of it is managing what's in the environment, the people, places, things, and events, but then when they find themselves, what they can do, and then overall, how can they be in a much better position to manage them when they should come upon people, places, and things which trigger them to smoke. All of this is to help strengthen, to use local language, the willpower or the frontal parts of our brain that helps us say no to things. If you want to think about it, all of this helps empower that part of the brain, which actually stops us from smoking, drinking, etc. So that's what you're trying to do, and help strengthen that part of the brain through this behavioral intervention. Now, what are the signs that medications need to be adjusted? Clearly, we need to do a meds check. Are people actually taking the medication? You'll be surprised how many people are missing their medication. So I often ask how they remember when they take it, how do they remind themselves. I will often even say, it's easy to remember the morning dose, but it's hard to remember the second dose. So how do you remind yourself what's happening? Side effects. Are there any side effects that are, typically with these drugs, it's the nausea, it's the vivid dreams. Those are the kinds of things. Some people who are especially with people with diabetes, they will have fluctuating blood sugars, and sometimes if they quit, their insulin sensitivity comes back, and they'll suddenly get a hypoglycemic episode. Now, it won't happen with metformin if somebody's on metformin, but it'll happen if they're on insulin or something else. They'll drop their blood sugars. On the other hand, if they were the ones compensating with sugar, they'll end up pushing up their blood sugar. So you have to pay attention to what these side effects are and what's happening. And clearly, what other prescriptions are they on? Are they taking other medications that could be interacting? And then what are the milestones that they're able to achieve, and therefore you adjust your medications across that. So now I'm going to bring up the issue of milestones. I mean, most cessation programs, if you look at it, over time have been built on, and most behavioral interventions are built time-based, which means everybody gets 12 weeks of a program or 4 weeks of a program or 1 week of a program or whatever it is. It's time-based, and it's given to everybody, and it's not personalized to what that person is able to do. So what some of the recommendations in the literature are to move to what are known as phase-based treatments, and it's evolving, but our evolution is to break it down into milestones achieved, so that it breaks it down for the person as to what are the steps that they need to take to become completely tobacco-free, and what does it do. So, and what are the activities they have to do under each stage to get there. So for pre-cessation, typically it's getting motivated and getting ready to take that quit date. And you know pre-cessation is over when that person takes that, makes that quit attempt, goes 24 hours without a cigarette. And that's an important milestone because each of these milestones that I tell you are correlated with each other. So if somebody makes 24 hours, it's more closely correlated with making the next 7 days, which is then more closely correlated with making 30 days, which then goes on to becoming 100 days, and so on and so forth. So what we want to do is get people to think about their milestone, and then if they can make that quit date, can they make it through 7 days of withdrawal? And often I will couple that if somebody's coming to quit smoking. Your milestone 1 is to make that quit date and then make 7 days, and keep going till you make the 7 days. Now, some people can do that all in one go, and some people they can make 2-3 days and they come back, and then it takes a while to get to 7 days. And you're adjusting it along the way. The making it out 30 days is typically where no longer is the withdrawal and the motivation an issue. It's really the habitual aspects of the automaticity, which really the subconscious aspects of this behavior, this addiction that has happened, that has been internalized, and that is very responsive to both what we call internal and external cues. So what's going on outside of them and what's going on inside of them. That's what drives them to smoke. So breaking those connections, creating an extinction between all those cues and triggers in the environment and tobacco is where you're trying to break it. And the colloquial term is obviously breaking the habit part of the smoking addiction. And generally, what then emerges if the habitual part is broken, what emerges as the dominant reason why people go back is actually stress response systems. Because when people are under a stress system, their body releases cortisol, it releases adrenaline, and what that does is it weakens that willpower part of the brain. It weakens the frontal lobe, and it causes the person to instead of staying and dealing with things, it causes them to now either a flight or fright or freeze response, and they'll seek comfort. So that's how they'll end up going back to smoking. And so generally, that is an important one. And stress can send people back even after that 100 days. But after about that 100 days and getting into 3 months to 6 months plus, really the person has to start moving into shifting their identity from being a smoker to an ex-smoker to somebody who doesn't smoke at all. And once that identity comes in, that also becomes protective. So there's a lot of work to do to become completely smoke-free, and these are sort of the milestones where we see people and where they often need help. So this is a study by Gilpin which looked at what is the probability that if people who quit, and how long will they remain abstinent? So essentially, if people and they follow them in follow-up, and 91% they had good baseline data on them, is that if they went less than a month, about only 12% stayed abstinent in follow-up. So you'll see that. If they went between 1 to 3 months, you sort of almost double that. And if you go more to 6 months, you again almost double it. Between 6 and 12 months, it seems sort of, again, as you'll get a percentage abstinent, but it doesn't seem that much more. But getting out to 1 to 2 years, you'll get 76% abstinence, staying abstinent. So, and to get to that 90%, it really takes about going smoke-free for 5 years. But notice that it never goes down to 0. So this is best, tobacco addiction is best considered within the context of an addiction as a chronic relapsing condition or disorder, which once you're a smoker, going back to even a single puffle can pull you back, and you have to be really careful. That's the message, and that the longer somebody goes, the longer they'll be able to stay abstinent and vice versa. So it's this thing that goes, that each one begets the other. So helping people make it over that threshold is important. And so it's important to get that in early remission, but they need to get into that that recovery. So I'm just going to finish off one more milestone, and as to why I brought the milestone up is because they want to, if you look at the relapse curves and you look at the rate of relapse, you take a look at all these studies put together, you'll see all this is, each line is a study which is showing us relapse and the number of days of continuous abstinence, and you can see that most people are relapsing before 100 days. So within that 3 months, almost like 90% are relapsed. But after that, if you haven't relapsed, your probability of relapsing drops really dramatically. So what the sort of idea is, that is, if we've got people coming in, and if we can push this curve to get them beyond that 100 days without smoking, then maybe 90% of them will stay quit. And that's the holy grail. That's why we want to get people beyond that 100 days to see if they can. And sometimes it helps people situate their milestones. So I have got a target to make it to 100 days, but I break it down into 1 day, 7 days, 1 day, 1 week, 1 month, 1 quarter. And I've been surprised how many patients actually recall that back to me in follow-up appointments, because they remember that. They say, hey, doc, I've made it out to milestone 2 and I'm at 7 days, and I'm really struggling with getting out to milestone 3. So one, it doesn't help them, it helps them stay in the process. They don't lose their confidence. They're saying to me, previously I would have just dropped out of treatment. No, I went back to smoking. It was all or none. It was all lost. And now I know what I need to do. I know I can go 1 day. I know I can go 7 days. So I need to just get back to that level. And for those of you on this call who play video games, that's how video games are set. You make it up through levels, and you keep playing till you cross levels rather than giving up. So we're noticing that this mechanism is taking away that dialogue from success, failure, and moving much more closely to milestones achieved and where am I going. So I'll just go to the next round. Okay, so, and then I'll come to the questions. So let's summarize what we want to do with this gentleman. We have some options. We assess his motivation. We assume if he's motivated. We provide him and he has a drug benefit coverage, and after discussing with him, he wants to do it. We will start varenicline as the first line. And monitor him, make sure his baseline PHQ-9 is okay, follow up, advise him about any mood changes, advise him about any side effects, dreams, etc. Ask him to pull back on the coffee, monitor his response to his other medications. And when at 4 weeks when he shows up, find out how he's doing, find out if he's quit completely. And with that olanzapine that he was on, when you're smoking, you clear about 1/3 more of the drug than you needed. So at that point in time, and when he shows up in 4 weeks, you ask him, so how's your medication going? Are you, are you sleeping more? Are you less tired or less anxious? And all of those things, if that happens, I would actually not reduce the olanzapine. I would reduce the clonazepam first, because that clonazepam is not doing anything other than interfering with him cognitively. So, and if all that anxiety that he was experiencing was because of his tobacco use, a lot of that will disappear. And I'd rather let the olanzapine do its job before reducing the olanzapine. And clearly, all his other cardiovascular risk medications will do better. They will help him. His cholesterol will respond better. His antihypertensives will do better. He will do better from a risk reduction perspective. Clearly, we didn't talk about his blood sugars, but it would be important to know, because these medications are metabolically active. I would check his blood sugars, check his diet, make sure he's not becoming insulin, he's not crossing into prediabetes or diabetic, make sure he's getting, paying attention to diet and nutrition and physical activity. And so those are the ways I would move through him in follow-up. And so in summary, I'll follow the Canada guidelines. I assess their readiness. I ask. I act. If they're not ready to quit, I help reduce the ambivalence with MI. And then I prescribe varenicline, bupropion, NRT, and I provide behavioral supports in tandem and milestones. With respect to using cytosine, which is available in some pharmacies and available online for about $75 for a month, its safety and use in people with schizophrenia have not been established, but I think it's worthwhile knowing that it is available in the Canadian market. It is similar to varenicline, and it's a shorter acting medication, so maybe this could be something that people will try, but of course it's not covered, unfortunately, and will require some finances to go towards it. But clearly a great option for those who want to use a natural product to quit smoking. So I'm going to go back and scroll through all the questions that have come up on the chat, and I'm going to see if I can actually blow it up. Maximize. Yeah, okay. So we will start with the first question. Yeah, so some experts say we should use a 3A approach, ask, advise, act, and the 5 A's. And I agree. In other words, don't need to assess motivation to quit unless signs of ambivalence or resistance when attempting to act. Could you comment? Absolutely. It's there when you have more time to do the assessing the motivation. In part, I think if you're a novice, sometimes when people assess motivation and the person says, I'm not ready, they just drop it. And that's the problem, because they aren't offering treatment. So I think it is important to offer treatment to people, and I would say the motivation doing is part of the treatment. And if you have a connection with this person, then I would engage them in that and say, okay, let's get you optimized for the treatment. Now, in some cases, pre-cessation pharmacotherapy is useful. In fact, varenicline can be used for a month before the person makes the quit attempt, and bupropion is a couple of weeks. Nicotine replacement has an indication for reduce to quit as well. So I think you've got to decide on your patient population and do that as opposed to the 5 A's. But you're right. Ask, advise, and act is a much faster way and a better way in busy clinics as a way to move forward. If you have the time and have the expertise, then absolutely assessing ambivalence or resistance is important. I'm sorry I couldn't fix the feedback. Hopefully that got fixed over time. Motivation is not a predictor to quit in general, because motivation is very fluid. You can have, it doesn't matter what motivation they came into the clinic with. It matters what they left with. So if you are able, that's one of the reasons why I don't go by stages of change, is because if somebody comes in not ready, I should be able to have a conversation that they leave with some more readiness to make a quit attempt and make the quit. So the problem with this is that motivation at baseline doesn't necessarily predict quit. However, you do need motivation to make, because the other person just drops out of treatment. Yes. So bupropion has its own drug interactions and interact with some medications. The bupropion and smoking and nicotine itself is not an issue to worry about it, but it's interaction of the 2D6, which is an enzyme that can metabolize some antipsychotic medications. So you do need to make sure that they aren't on. So, for example, if they are on venlafaxine, they may need a reduction in dose. But other than that, yeah, you do need to be mindful of their drug interactions, and I would definitely include the pharmacist if you are not a prescriber, and if they are going to the pharmacist, the pharmacist should know all the medications the patients are on. And as you know, in Ontario, pharmacists have the right to prescribe, and so pharmacists on this call could certainly take that on, and in fact, we have a training program for pharmacists who want to become better prescribers, or even nurse practitioners, and anybody else who wants to become a better prescriber can take our course. So the EAGLE study has many limitations, as you rightly pointed out. It did not include people who had unstable psychiatric conditions, so this is why we used a case where somebody's stable psychiatrically. And the other thing is, you talk about they did not titrate the NRT to to optimize the dose. So this is fixed dose NRT as opposed to a titrated dose of NRT, and so that is one of the problems with that. Yeah, and exactly, you're absolutely right. One pack is not enough, and that's why our guidelines help you titrate to that. And again, as Dr. Kara points out, EAGLES was limited to on-label dosing, absolutely, and that's what happens in these studies. Remember, the study was actually designed for safety, not necessarily for efficacy, and the good point is that the safety part for the study really showed that there was no difference in neuropsychiatric or other side effects, including cardiac side effects in the study. The other limitation is actually, it's not in the EAGLE study, but there's another study that Pfizer conducted in adolescents, so less than 17 years of age. Varenicline does no better than placebo, and it doesn't do well at all. I mean, their absolute smoking cessation rate is very low, and in fact, the lower dose of varenicline seemed to do better than the higher dose, and those data were presented at the SRNT meeting in February, and with that publication, and which is very interesting, which means in underage smokers, nicotine replacement may be the way to go forward, but it's still unknown from a guideline perspective what to say, but that's emerging data. Is there room for short-acting NRT? And we have used short-acting NRT with my patient who has 100 cigarettes a day. Now, this is rare. It's not everybody needs to go up to that. What is the total maximum dose? I don't think it's known what the total maximum dose is. The question is, how much is the person smoking? I mean, if you have somebody smoking 100 cigarettes a day, I mean, this person was smoking 10 cigarettes all at once. That's unusual. You don't usually have that. And I don't know if anybody actually knows what the total max is, but if people have developed a tolerance, they don't seem to have, they're not hypertensive, they're not tachycardic, they're not toxic, they're not complaining of headaches, they're not throwing up, nothing's happening. They're not, there's nothing that we know that they're doing. But what are the long-term risks? I mean, long-term risks of nicotine are, as what we know, is the insulin resistance. So if they're going up, they're probably increasing their insulin resistance. And secondly, what they're probably doing is, if they have cancer, nicotine is not a carcinogen by itself, but it can be a cancer promoter in the presence of other carcinogens. So we don't know. So I think the ultimate risks are, not known. And are the risks of poisoning there? Yes, if you have somebody who's not able to regulate and manage. And this happens, I mean, this potentially theoretically can happen to people who have significant cognitive deficits, like because of head injuries or dementia. I would be very careful. I would not be giving them unlimited access. And then once you're getting to that dose, you're also asking, like, why am I not using something else? I mean, is there a reason why we aren't combining them with nicotine replacement plus varenicline, or nicotine replacement plus bupropion, or bupropion plus varenicline, or going to some of the second-line medications like nortriptyline or clonidine? Those are some of the things that I would start asking and thinking about. But those, again, are all off-label, and those would be, need a consultation, really. Neshma, thanks for putting up what Smokers Helpline is and where it's available. So please look at that, and the text messaging service as well, which is an evidence-based resource. So clearly, that's great. Yeah, and setting a quit date has been anxiety-provoking for a number of my clients. And so how do we ease that anxiety? We often talk about practice quit dates. Is there a day to set a time where you can try to go for 24 hours? So we don't say setting a quit date forever, right? We say a trial of going 24 hours without smoking a cigarette. And so how could you add up those hours? So currently, you're sleeping 8 hours, you're not smoking at that time if they're not smoking. And how can you push that further? And how can you add the hours either before you go to bed that you don't smoke? And so start counting it. Rather than setting up the anxiety that, does it mean I never have a cigarette again in my life? That fear drives them really problematic. And this fear about failure, So one of the things we talk about is that quitting is a process, not an event. And we often say that if you went and you try to quit and nothing happened, or you weren't able to get it, we learn something. It helps us adjust medications, helps us adjust the treatment with you. So that's the important part of it. So making it low stakes is one of the ways in which we've had people reduce that anxiety. When people are talking about anxiety, at the back of my mind, I'm finding out that these people have a high attachment to their cigarette. It's not, and the attachment being almost like a psychological attachment. This is the time when they're talking about cigarettes as their friend or their comfort or their lover or what have you. So I'm keeping that in mind. And we're really talking about these little practice sort of, increasing the distance. It's like creating a greater time between you and your cigarette and managing that. So those are some of the ways in which people can we approach it. We also use the reduce to quit for this group rather than setting a fixed quit date. But you want to quit date within a horizon, as opposed to, I'm planning to have a quit in 3 years, but I want to be on nicotine replacement and smoke all the while along.